Welcome to the Optimizing Care for Patients with IBD Highlights from the Advances in IBD Conference webinar series. I'm Richard Geswell, President of the Crohn's and Colitis Foundation of America. On behalf of CCFA, welcome everyone, and thank you for attending today's program, which is supported by an unrestricted educational grant by Centocor Ortho Biotech. This program is our first webcast series targeted to healthcare professionals, and we are very excited to offer this program as part of our commitment to furthering professional IBD education year-round. The content covered in today's program stems from CCFA's 2010 Annual Advances in IBD Conference, which is the leading conference on Crohn's disease and ulcerative colitis. The 2011 conference will be held December 1st through 3rd in Hollywood, Florida. For more information regarding that conference and registration, visit advancesinibd.com. As a reminder, this webinar is the second in a series of 3 webinars. Be sure to register for the final webinar that will be held April 26th at 6 p.m. Eastern Standard Time. To register, click on the Upcoming Presentations tab in your webinar series profile and select the April 26th program. And now it's my pleasure to introduce Dr. Russell Cohen from the University of Chicago Pritzker School of Medicine, who will be moderating our program and will also be the first speaker today.
Thanks, Rick, and thank you all for joining us tonight. Welcome to tonight's webcast, Current Controversies in IBD Treatment, with our distinguished faculty, Dr. Tom Ullman and Dr. David Rubin. My name is Dr. Russell Cohen, and I will be your moderator tonight and also be given the first presentation. Following the debate, we'll open up the program to a short question and answer session. Please submit your questions at any time during the program via the web by typing in the Ask a Question text box and clicking the button to submit. We will take as many questions as time allows. You can collect your continued education credit after completing the evaluation form at the end of this program. If you should need technical assistance, please type your inquiry into the Tech Support box on the left side of your screen and click the Send button. If you are disconnected from the webcast, you can log on again using the instructions provided to you for assessing this presentation. If you cannot log back on with these instructions, please call 877-843-9272 and ask for assistance from one of our technical support representatives. It is now my great pleasure to begin today's program with an overview of current controversies in IBD treatment by looking at new therapeutic goals, the real issues regarding early aggressive therapies. The educational objective for tonight is to discuss at least 2 potential advantages and disadvantages regarding early aggressive therapies. The goals of treatment for patients with inflammatory bowel disease have traditionally been listed on the left side of the slide as inducing remission, maintaining remission, steroid sparing, preventing complications, improving quality of life, and restoring and maintaining nutrition. Many of you have probably seen this before. However, nowadays, with new therapies, there are some new goals of treatment that actually may be attainable. Healing the mucosal lining of the bowel, limiting hospitalizations, perhaps limiting surgeries, also being cost conscious when making treatment decisions with new and pre-existing therapies. Let me show you some data from the top-down study. The basis of the top-down study is in the bottom in the left blue box, where patients with Crohn's disease who had never been on anything past corticosteroids or actually never been on anything past aminosalicylates, if anything, were randomized to get either step-up therapy for the moderately to severely active Crohn's disease with corticosteroids, and then corticosteroids again, then immunosuppressants, then finally anti-TNFs, or top-down therapy with early aggressive therapy starting initially on infliximab, 3 infusions, 5 milligrams per kilogram, weeks 0, 2, and 6, and azathioprine at 2.5 milligrams per kilogram body weight, presuming they have a normal TPMT level. The results from this study were startling. Patients who had early infliximab and azathioprine on the left side of the screen had corticosteroid avoidance, had higher remission rates at both weeks 26 and 52, had evidence of mucosal healing, while no safety cost. There was a similar safety between the two groups. I think that probably the most impressive data is the mucosal healing data, looking at the right side of the slide. Despite the fact that many of the patients who received infliximab only got induction infliximab and then were retreated down the line if they had recurrence rather than getting maintenance therapy as we do today, there was still a dramatic difference at 2 years in complete endoscopic healing, where patients who had the top-down approach had 73% complete endoscopic healing versus just 30% with step-up therapy. These were very impressive findings that have clearly not been seen with other therapies up to this point. Let's look at the ACCENT-1 trial. This was a trial of infliximab in luminal Crohn's disease. Patients in ACCENT-1 received infliximab at week 0, and then those who were responders subsequently received either infliximab 5 milligrams per kilogram, infliximab 10 milligrams per kilogram, or placebo at weeks 2 and 6, and then were put on maintenance therapy with those agents. What the study showed was that infliximab induces remission, maintains remission, is corticosteroid sparing. However, it also showed that it decreased hospitalizations, hospitalized days, and surgeries. So I draw your attention to this right side of the slide. The top box looks at patients who are in remission less than 25% of the time on the left side, up to 100% of the time on the right side. The average number of events is actually the hospitalization data. You can see a clear difference that patients who are in remission at least 3/4 of the time had far lower hospitalizations than those who were in remission less than 25% of the time. Below that is the surgical data. Again, patients who were in remission at least 3/4 of the time on the right side of that graph had very low rates of surgeries compared to those who were in remission less than 25% of the time. Cost studies have suggested that hospitalizations and surgeries are the most costly interventions in Crohn's disease, not medications. And this study supports the notion that intervention with infliximab can decrease both hospitalizations and surgeries, as well as the other findings listed on the slide. The ACCENT-2 trial was infliximab in fistulous Crohn's disease. Patients who all received an initial induction week 0, 2, and 6 of infliximab, 5 milligrams per kilogram, were then randomized to receive placebo or infliximab for maintenance after they responded. Again, there were major clinical outcomes in patients with fistulous disease doing much better with infliximab than with placebo. But what you may not have seen is the hospitalization and surgical data. Shown here on this slide, patients who received infliximab versus placebo had far lower mean hospital days on the left, mean hospitalizations on the upper right, all surgeries on the bottom left, and major surgeries on the bottom right. So again, it's not just the clinical outcomes from the clinical trials that are impressive, but also looking at some of the other issues that perhaps may have not been made the front lines when the studies were first published and presented, that these are not just effective therapies, but they're actually decreasing hospitalizations, hospitalized days, surgeries, and even major surgeries with these interventions. At the University of Chicago, I led up a study where we looked at patients with Crohn's disease before and after they started their first treatments with infliximab. This is way back in 1998, 99, and 2000 when this medication was released. And what we showed was that patients, when they were started on infliximab, followed up over for initially a 1-year period and then a 3-year period, had decreased in hospitalizations, hospitalized days, surgeries, and GI surgeries. There were numerous other economic outcomes from that paper shown with infliximab. Things such as outpatient visits, GI outpatient visits, endoscopies, radiographs, emergency room visits, and other outcomes were all dramatically decreased once the patients received infliximab. In the United Kingdom, they then did a similar study looking at the impact on costs with infliximab for patients who received the drug with Crohn's disease and compared their 6-month period prior to receiving infliximab to their 6-month period after receiving their first infliximab. The cost data is listed in British pounds, but you can see they took the cost of the infliximab for the 353 infusions at roughly 563,000 pounds, and then they calculated the direct cost savings from decreasing issues such as surgeries and hospitalizations at 591,000 pounds, and showed an overall cost savings of roughly 138 pounds per patient, which at exchange rates at the time was about $216 per patient. So this is cost savings in patients with Crohn's disease who are treated with infliximab in the United Kingdom. What about safety issues? There's a lot of attention, appropriately so, given to safety for our agents. Let's look at the data that we have now collected from a variety of different sources on infliximab. First, let's look at the TREAT registry. The TREAT registry follows roughly 6,200 patients, half of whom had infliximab, half of not, for the treatment of their Crohn's disease. One of the major outcomes, I think that is very concerning for many of us, is serious infections. While one may anticipate that serious infections were increased with patients receiving biologics such as infliximab or immune suppressants such as 6-MP azathioprine or methotrexate, the data shows otherwise. Those patients had no clear outcomes that showing increased serious infections. However, the current use of steroids and the current use of narcotic analgesics clearly increased the serious infection rate 2 to 3 times higher than would be expected, and certainly higher than the other medications in this chart. Tuberculosis was not initially known to be a problem when infliximab first came out, but reactivation in tuberculosis subsequently followed as the drug obtained more use in the United States and worldwide. What's shown here in this graph is the increase in reported cases of tuberculosis of patients treated with infliximab. You can see the graph quickly rises up to a peak. The black arrow shows when the TB education program was initiated, whereby patients would be screened for tuberculosis infection prior to receiving infliximab and currently prior to receiving any anti-TNF therapy, prior to proceeding with the drug. And you can see the European Union data showing a dramatic decrease in the cases of tuberculosis observed with infliximab, and this has been shown also with other anti-TNF agents. The top right shows opportunistic infections in patients reported with infliximab. You can see a combination over a period of time listed there with pneumocystis, listeriosis, atypical mycobacterium, CMV, herpes, salmonellosis. However, look at the number. The number is 37 in 99,000 patients exposed. So the rate is very low. You do need to be aware of that. However, the rates are still extremely low. And finally, viral exacerbations. It's now well known that one should make sure patients are not carriers of hepatitis B prior to initiating infliximab or other anti-TNFs. Patients who've had herpes virus infections may have recurrence and may need to be put on suppressive therapy. It generally has not been advised to give anti-TNFs to patients with HIV, although those recommendations actually have been softened as better agents for HIV have been established. Human papillomavirus, Epstein-Barr, and others have risen. Vaccination concerns, basically anyone on immunosuppressants should not get live vaccines. The other main area of concern has been neoplasms and mortality. Again, the TREAT registry showed no increase in patients in either all cancers, the first row, or in lymphomas, the second row, when you compared infliximab to non-infliximab recipients for Crohn's disease. The odds ratios, as you can see, are around 1. The listing of cancers for patients with infliximab versus other therapies is relatively identical, or nearly so. We were very shocked when a few years ago the issue of hepatosplenic T-cell lymphoma arose, predominantly, as we've been told, in young men. Most, if not all, have been exposed to azathioprine, 6-mercaptopurine, and the anti-TNF agent. As many of you know, this has been reported in the immune modulators alone. If there have been rare cases in anti-TNF agents alone in patients who have already had other reasons for immune compromise, it does appear that the combination may increase the rate, but it's still extremely few cases overall. As far as mortality, remember the previous slide I showed you with serious infections? Well, this is almost a duplicate. Current use of infliximab or 6-MP azathioprine and methotrexate, the first two rows do not show any difference in mortality. However, steroids clearly are linked to mortality in Crohn's disease, and actually the narcotic analgesics almost reach statistical significance in also being a predictor of mortality. There have been a few different registries looking at mortality rates in Crohn's disease patients on and off these agents, and most of them have not shown a convincing evidence of increased mortality. So that concludes the formal part of the presentation that I was going to give tonight, and very shortly I'm going to ask the two panelists with me to discuss these issues. But first, we are going to revisit the question that you answered during the pre-survey. Serious infections and death in Crohn's disease have been linked by the TREAT registry to which IBD medications? A, corticosteroids, B, azathioprine, C, methotrexate, D, infliximab, E, all of the above, or F, I'm not sure. So why don't you take a few seconds now and make your choice, and then we will provide you with your results. Okay, so in this survey, 61% of you reported that corticosteroids were the agent that were linked to serious infections and death in Crohn's disease, which is the correct answer. The other roughly 35% of you listed all the above, which actually has not been the case. As we showed from the TREAT registry data, azathioprine, 6-mercaptopurine, methotrexate, and infliximab have not been linked to serious infections or death by the TREAT registry. Prior to tonight's program, you were asked these questions as well too, and the results are very different. While 61% of you correctly answered after seeing my presentation corticosteroids, prior to the program, most of you, about 40%, said you were unsure. Another 26 or 27% said all the above, and only 14% said corticosteroids. So hopefully this shows a good teaching point came across about the risks of corticosteroids in patients with Crohn's disease. At this point, I'm going to turn to my panel. As I mentioned, Dr. Thomas Ullman from the Mount Sinai School of Medicine and Dr. David Rubin from the University of Chicago Pritzker School of Medicine, and ask for their opinions regarding the issues that we had during this presentation. Tom?
Sure. Excellent presentation, Russ, and you covered a tremendous amount of ground in there. And I think it's always reassuring to see some of these data represented as they have been at a number of meetings that we've all had to attend. I think particularly the mortality and infectious risk data are very important. Obviously, those are still ongoing and being collected. And I'm hopeful that the early signal that we've had with the TREAT registry and others is going to continue to hold up. Obviously, so many of us have a number of patients on these agents. And, I think that we'll revisit some of these same issues that you brought up in the mucosal healing and symptom discussion that David and I are going to have shortly.
Yeah, so David, has your experience been that patients have been concerned about these issues as well, serious infections, death? What comes up in your conversations with them?
Well, anytime you bring up that you're going to use immunosuppressive agents, or for that matter even steroids, to treat a chronic condition like IBD, patients bring up these issues. And if you haven't actually brought it up yourself in the discussion, and they look to the internet and learn this from some other source, you're really doing your patient a disservice. You should really be addressing all these issues when you first discuss your treatment strategies. But I wanted to make a couple points based on your very nice presentation. The first one was that in the top-down and step-up study, the primary endpoint was the 2-year clinical remission outcome. And it was the same in both step-up and top-down. So you nicely made an argument that you achieved more mucosal healing with top-down, and we're going to talk more about mucosal healing. But one of the most challenging aspects of this entire field and in embracing earlier treatment like this has really been who to treat this way. Which patients should we identify and how are we going to do this? And then how do we talk to patients about doing that effectively? The second issue is really an important point that you made, which is that the patients who were in top-down and step-up, by definition, because they had to be steroid naive, were short-duration patients. In other words, treating earlier does make a difference. And I think when we go back to our patients in our general clinics and in our practices, if we realize that we're often treating patients who've had disease for longer, who failed many therapies before we do this, some of the outcomes that were seen in that study might not translate as well.
You know, David, I think you bring up a good point about how these are earlier patients in their therapy because obviously they haven't seen even corticosteroids yet. One thing, Tom, I wanted to ask you is now think about patients that you've seen at Mount Sinai. I mean, how many patients have you seen at Mount Sinai who within a year or two of their initial diagnosis are already not only put on steroids, but in the top-down step-up therapy, as you know, 70 to 80% of the step-up patients ended up on immune modulators within the first 2 years. I mean, do you think that that's really reflective of what people are doing in the community?
Yeah, I think that we've all had the luxury really of seeing so many different trends over a really short period of time since the design of the top-down and step-up therapy. I think that both the top-down and the step-up modalities in that study as it was designed are both antiquated to some extent. You know, then we were using infliximab, the so-called top-down, really as almost on an as-needed basis, and that's how that study was designed. We don't do that anymore. We know that regular interval dosing is more effective therapy. That came out since that study. And similarly, the step-up had a couple of rounds of corticosteroids, as you had described, before they saw their first dose of immunomodulators. And I think we have seen the community, even while we're still quoting this study, I think we're seeing the community catch on to that as well. I think that we have much more aggressive step-up for those practitioners who are still, I don't want to say committed to, but who are still more comfortable with that round or that route of therapy. And I think we're seeing more early aggressive infliximab use as well. So while it used to be very common to see patients who remained naive to both of these things and sort of had an early consultation at a place like Mount Sinai or University of Chicago where you guys are, I think that seems to be less common now.
So I just have to make a point because when we keep saying early aggressive or top-down, which are the terms that are used, and they're terms that were used even in these manuscripts and these studies, we're conveying that this is potentially a more dangerous strategy in some ways. So there's nothing wrong with saying that because that's how we're trying to change the way we treat people. But what I want to emphasize is that ideally we would be talking about effective therapy at the right time for the right patients. And so there's a lot that I just said in that because who are the right patients, what is the right time, and which are the right therapies. But that's really what we're struggling with here, right? So we could figure out which patients are the right ones and treat them effectively with a combination approach that takes into consideration the challenges we face. Then we're going to hopefully have the outcomes that you mentioned, such as reduced hospitalization, surgeries, or even direct costs.
Well, Dave, I mean, a lot of the clinicians want to know, when should I pull the trigger? When should I go to immune modulators? I mean, just generally speaking, your average Crohn's patient, what was it that would make you say, bam, go to immune modulators?
Well, in my practice, if the patient has perianal disease, they're automatically going to go on to an anti-TNF therapy, and I'm now using combination therapy in all my patients, meaning a concomitant immune modulator or methotrexate with that strategy. If they have deep ulcers throughout their bowel, I'll use that as a prognostic marker that I need to go to it. But the traditional thinking about this is your patient who is prescribed corticosteroids, needs corticosteroids, or is steroid dependent is somebody who you should definitely be going towards an immune modulator or an anti-TNF. And you use the term pull the trigger. It's also contributing to the general perception that these are dangerous things to do, when ultimately we're really just trying to make people better and keep them well. So I'm just trying to change some of our terminologies here.
Well, and you raise a larger point, and the semantics of so much of this can sometimes get in the way. For us, it can certainly get in the way for our patients as well. We've thrown around terms like immunomodulators and immunosuppressants when what we mean are thiopurines and methotrexate, at least in the context of this discussion that we're having, and corticosteroids to some extent. Sure. There's actually a study that is about to be published in the IBD journal where at the doses that we use conventionally for the treatment of thiopurines in fact causes no immune suppression in terms of response to vaccinations. So there are a lot of sort of terminology issues that we need to work around, and this gets particularly tricky with our patients. We don't yet know who the right patients are or aren't, but it'll be, we're starting to gain some signal on who they are.
Okay, right. So I guess to pull the trigger was a Chicago term. So we're now going to move on to the debate. You've already heard from some of the speakers. I want to actually formally introduce them. Dr. Thomas Ullman, sitting immediately to my right, is from the Mount Sinai School of Medicine in New York City, and he'll be talking about why mucosal healing, not symptoms, should be the endpoints of therapy. To his right is Dr. David Rubin from the University of Chicago Pritzker School of Medicine, and he will present the counterpoint. Symptoms, not mucosal healing, should be the endpoints of therapy. Dr. Ullman, the floor is yours.
Well, thank you, Dr. Cohen. It's a pleasure to be here, and greetings to all of you out there. So as you mentioned, the title of my presentation as part of this discussion or debate is that mucosal healing, rather than symptoms, should be the endpoint of therapy. I have the following disclosures for those of you keeping score at home, and just want to move on here. And really what we're talking about is this larger problem of how do we go about assessing a response to therapy, any therapy, regardless of semantics, in patients who have the same disease but who may have different clinical manifestations. And how do you determine if that therapy is worth continuing or worth moving on to a different therapy? Back in the old 20th century, we really went with these symptom-based indices of activity for the purposes of clinical trials, and really these were designed to be substitutes for a clinical judgment and a physician's global assessment of what was or wasn't happening with the patient. Here in the 21st century, where we now reside, we have a different kind of answer, I believe, and we really should be measuring disease activity with our eyes. And how do we really do that, and what do I mean? Well, the problem with the Crohn's Disease Activity Index, as well as really the other symptom-based indices in both ulcerative colitis and in Crohn's disease, are that they're disease-focused, but not necessarily disease-specific. So items that are part of these multidimensional indices include abdominal pain, fatigue, frequent or loose bowel movements, whether or not a patient is using antidiarrheals, which, when you get down to it, to a certain extent, starts to sound a whole lot like irritable bowel syndrome. And so you can have all of these symptoms really without having any mucosal disease. But we know that it's mucosal disease that is the hallmark of these illnesses. As a result, many of these indices were inconsistent. The effects of surgery were really not counted in these indices. The effects of extraintestinal manifestations that are sometimes unrelated to disease activity could overly influence a score as well. Additionally, my boss, Bruce Sands, back home in New York, demonstrated previously that the basis of the scoring for these indices really isn't uniform. And so the Crohn's Disease Activity Index probably isn't measured the same way from institution to institution or even from practitioner to practitioner. Additionally, these multidimensional indices really lack good prognostic meaning. They don't predict the future very well. They only tell you what may or may not be happening at that one moment in time. They're also quite cumbersome, and as a result of all of this, no one really uses them in clinical practice, and we rely on a physician's global assessment to tell us what's going on and really take a laundry list approach to how a patient is doing at any one moment in time to determine whether or not our therapy is currently effective or not. There are, however, some objective measures of inflammation. There's colonoscopy, where we also like to take a look into the ileum, particularly in Crohn's disease patients. And there's some scoring systems that are out there for this. There's the CDEIS, or Crohn's Disease Endoscopic Index of Severity, a more simplified version of this called the SES of Crohn's disease, or Simplified Endoscopic Score of Crohn's disease. And for ulcerative colitis, as most of you out there are aware, there are a whole number of different scores, all designed to look at how active the inflammation is. We also, in the 21st century, have video capsule endoscopy and some scoring systems associated with it, though while not completely validated, are certainly frequently used. There's MR enterography and its cousin CT enterography that can take a look at how much active disease there is or isn't. small bowel series, sadly a dying radiologic procedure, at least in New York, is out there as well. And we'll have some upcoming inflammatory indices that are out there that are a little more global and based in part on some of the same parameters or variables that go into these endoscopic and radiographic indices, one named after the late great Marc Lemon, and the Lemon Inflammatory Index will be coming around pretty soon as well. And it turns out that these indices really tell us a lot more about what's going on in terms of how inflamed a patient is or isn't, as compared to some of the conventional multi-system or multi-dimensional indices that are out there. Here you see a study done by Jones and colleagues that was published a couple of years ago in Clinical Gastroenterology and Hepatology, where you have an agreement table that has heat shock C-reactive protein, IL-6, calprotectin, and lactoferrin, these latter two being measures of stool-based neutrophilic activity, as well as the Crohn's disease activity index. As you can see, the correlation coefficient is really quite poor between the amount of active inflammation that there is and the amount of activity there is as measured by the Crohn's disease activity index. And in fact, the endoscopic score seems to correlate much better with the other indices of active inflammation, although they're all problematic. None of these are yet perfect. So do these endoscopic scores matter? So sure, they don't correlate very well with the activity indices, but how much do they really matter? It turns out quite a bit. In this study by Mathieu Hellet from Paris, it turns out that deep ulcers are associated with a colectomy and with penetrating complications. And I sort of cleverly, I think, raised the question of, can the physician's global assessment do that? I don't think that it can. And what you see on your left figure is that patients are much more likely to remain colectomy-free if they're healed, whereas if they have deep ulcers, they're much more likely to have to undergo a colectomy. And then on the right, you see a similar kind of Kaplan-Meier curve where we assess the difference between mucosal healing and whether or not penetrating complications come. And it turns out that having good mucosal healing far less likely to develop a penetrating complication. So we have additional studies as well that support mucosal healing as a meaningful endpoint and having prognostic value. This from the ACCENT study that you, Russ, that you previously referenced in your presentation. And here you can see that patients who had healing at both visits in the ACCENT-1 trial, at both weeks 10 and 54, that these patients did very well and did not have any Crohn's disease-related complications. Whereas if you had no healing at either visit, you had a 28%, if I can read that correctly, and I think that's a 28% chance of having to be hospitalized. And so here you can see, along the same lines as outcomes that you were talking about previously, better healing results in fewer hospitalizations. Turns out, not only does better healing associate with fewer hospitalizations, but independent of treatment arm in this study by Schnitzler and colleagues, you were much, much less likely to have abdominal surgery if you had good amounts of mucosal healing. And you can see that the differences there didn't matter if you were on scheduled or episodic treatment, which I alluded to earlier. We now no longer do episodic treatment, in part because of this study as well as some others by Rutgerts and others. It turns out that it didn't matter which arm of therapy you were in. If you had good healing, you were much less likely to have an abdominal surgery. Similarly, as you pointed out, good mucosal healing was associated with a prolonged remission in that top-down study. Top-down there in quotes because it is such a great catchphrase, whether we pull the trigger on it or not. And it turns out that this really turns out to be a meaningful predictor variable of what's going to happen later on. So really some excellent prognostic signal that's being determined by mucosal healing. And really, in part, I believe, much more valuable than how the patient's doing according to one of these indices of activity. Finally, mucosal healing associated or is inversely associated with colectomy rates and ulcerative colitis. So better healing, lower rates of colectomy in patients of ulcerative colitis is demonstrated quite dramatically, I think, here by this Kaplan-Meier figure from the study by Frosley. Finally, I shouldn't have said finally on the slide before, better histologic healing results in fewer neoplastic complications in ulcerative colitis. This was demonstrated by Matt Rutter in a case control study back in 2004, and then both our group and David's group at Chicago were able to show again that less inflammation begets less neoplastic complications in patients with ulcerative colitis. So mucosal healing is associated with prolonged remission, fewer hospitalizations, fewer abdominal surgeries, fewer penetrating complications, fewer colectomies, and less neoplasia. So therefore, I believe it should be the basis of assessing our IBD patients for activity and prognosis moving forward. David?
Well, thank you, Dr. Ullman, for your persuasive arguments, and I always love the part where someone says finally and then they go to the next slide.
I blew it.
However, we did stay attentive, and that was an outstanding presentation. I am halfway convinced now, but I have to give my colleague Dave Rubin his due for the counterpoint of this presentation. Dave, the floor is yours.
Well, thanks, Russ, and nice job, Tom. The question here is not whether mucosal healing is a preferred endpoint or that when you achieve it, you can't have preferred outcomes. It's whether we should be treating to achieve it in 2011. And I would suggest to you that we can't do that yet. And let me explain to you a little bit more about how and why this is. So the first thing is that I am not arguing at all that mucosal healing is a great thing when you can get it. Deep remission, the term that we should all become familiar with now, that is associated with both symptom control and endoscopic mucosal healing, is associated with a variety of outcomes. Durable remission, less use of steroids and hospitalization, less use of anti-TNF therapies, and even in some preliminary work, the possibility of withdrawing anti-TNF therapy. That doesn't mean we should do that yet, but it's interesting and intriguing to see that. We also know that histologic healing is associated with less neoplasia, as Tom nicely summarized, and possibly with less hospitalization, especially in ulcerative colitis. These are all good, important points. Tom showed you the results from the top-down and step-up study in which the patients who achieved complete mucosal healing, regardless of which arm they were in, were then followed and compared to the patients who did not achieve complete mucosal healing. And in an additional 2 years of follow-up, so years 3 and 4 from the initial top-down step-up study onset, you can see that there were better outcomes. The point, however, is not that we should then start treating to achieve this goal, which would be a very lofty goal, but rather to appreciate that when you see this type of outcome with less relapses and less anti-TNF use over time, that is specifically after you've already achieved mucosal healing. And I should point out that in the top-down and step-up study, it was not the goal of the study to achieve mucosal healing. There was the secondary endpoint of assessing who got there. So let me show you the results of a prospective clinical trial that uses mucosal healing as the primary endpoint. In other words, treatment to achieve mucosal healing, not the flawed CDAI, not the ulcerative colitis disease activity index, and then associated that with clinical outcomes. Well, unfortunately, such a study doesn't yet exist, or if it exists, as it may be in its earliest stages, it's not finished yet. So I want to point out to you that what we're really asking here is in our clinical practice, should we be changing therapies based on the endoscopy or other markers demonstrating active inflammation, as opposed to continuing to rely on symptoms and a variety of other markers, such as laboratory findings, which weren't mentioned. So let's say that we wanted to start looking at mucosal healing on a regular basis in our practice. Well, it becomes very complicated. What is the actual definition? Should it be endoscopic? Could it be histologic? Could we actually use something that's less invasive, like a radiologic study, or even some other stool marker? What about when you would actually look? You don't want to look too soon, because then you might incorrectly assume the therapy you're using isn't working. And you don't want to look too late, because you may miss a window of opportunity to make changes. So we're really challenged in thinking about how we need to do this. And until we have better evidence with prospective trials demonstrating how to get there, I don't think we can start doing this in regular practice. And the last issue, which I'm going to make more of a point of, is how often can we actually get there? Or are we going to end up escalating all of our patients with the impossible goal of trying to heal them, and then everyone ends up on our maximal therapy with the current available strategies? So can we achieve mucosal healing in a majority of our patients? The reality is that we don't know. And Crohn's and ulcerative colitis are very different, so we can't necessarily extrapolate from other studies. And can we get there? Well, we know we can, but the answer is sometimes. So let me show you the results from an important study that was published in the New England Journal of Medicine in 2010. This is what we call the first comparative effectiveness study in IBD. The SONIC study took patients who were naive to azathioprine or 6-MP or methotrexate and naive to biologic therapies and randomized them to azathioprine alone, infliximab alone, or a combination of the two. These patients who had a moderate to severely active Crohn's by the CDAI were enrolled in this study and randomized to that endpoint. The primary endpoint demonstrated that the patients who got combination therapy achieved clinical remission off steroids more than the two monotherapy arms. A secondary endpoint was specifically looking at mucosal healing in patients who had ulcers at entry into the trial, because not all the patients who got into the SONIC trial had active ulcers. Again, the CDAI was used as the inclusion criteria. And what you can notice is it was only 44% of patients who actually achieved that mucosal healing. So even if we use the best therapies that we currently have available, you can appreciate that we're not going to get there in a majority of our patients. Now we can also extend this to adalimumab, and conveniently the name of that study was the EXTEND study, specifically looking at what happens with mucosal healing with adalimumab. So when you look at a study like this in which patients with active Crohn's, moderate to severely active, who were then enrolled and received open-label adalimumab loading, followed by randomization to adalimumab or placebo over time, you can appreciate that at the primary endpoint, which was week 12, the mucosal healing rate was only 27.4%, and that was in the arm that continued on adalimumab. The arm that was randomized to placebo that got open-label adalimumab had only a 13% mucosal healing rate. Now, when the drug was continued for a year in patients who were able to stay in the trial, after 1 year of ongoing adalimumab therapy, only 24.2% of these patients had complete mucosal healing. So it's important to acknowledge that we may not be able to get there in many, if not most, of our patients. Now, what if we actually extended this one step further and said, what about looking at the symptoms and the mucosal healing, that term deep remission that I introduced here? So there was actually follow-up of this study to look at how many patients had clinical remission by a CDAI as well as complete mucosal healing in that same adalimumab study. And you can appreciate that it was only 16%. So that's a very important point. At the week 12 primary endpoint, only 16% of the patients had symptom-free remission along with a complete mucosal healing. So if we were going to start treating everyone to achieve this endpoint, I would argue that we're going to be going through all of our therapies very fast in patients who are otherwise not having any symptoms. If you ask our patients what they actually want out of their management for their Crohn's disease and ulcerative colitis, they're going to tell you that they want to feel well. They don't want to have symptoms. They want to be able to plan social events and know that they have some control over their future. Ideally, if we've looked and they're healed, we can tell them that they're going to have some control. But in the event that they're already feeling perfect and we haven't looked yet, you have to know what you're going to do with the results before you actually scope or take a look with any other modality. So are you sure you need to look? In a patient who's feeling well with normal labs, other than performing a surveillance or screening colonoscopy, why would you look? And what will you do once you find those results? You should discuss that with your patient. You should make sure their insurance company is going to pay for it. And you should also make sure that when you go through the strategy of changing their therapy, you know what you're going to do if it doesn't work. So are you willing to escalate? Most of us say we can probably escalate within a class. In other words, we can optimize the dosing of therapies they're already on, and we're comfortable doing that. But are we comfortable going to an entirely new class of therapy? In other words, in the patient who's asymptomatic on azathioprine, would you be willing to jump to an anti-TNF therapy based only on mucosal healing? And that's an important question that I don't think we have the answer to yet. The other issue is really, will the risks of doing such a thing outweigh the benefits? And that hasn't been answered at all. So now your patient is stable and in deep remission. The next question is, how often are you going to look? If we're going to embrace this outcome, we're going to need to keep looking over time, and that certainly hasn't been achieved yet or described. My very final point here is that if you just focus on treating your patients to achieve symptom control, there's still a lot more improvement that we can do. In a national internet-based survey of patients with ulcerative colitis, we revealed that a majority of patients who answered this particular survey lived with active symptoms and didn't tell their doctors. So we could actually start by focusing back on communicating with our patients and making sure that we're achieving the clinical remission that is really part of our existing goal, and use mucosal healing to guide us in other ways. So I would just summarize by saying that the way to actually achieve and use mucosal healing in your practice now is to know what you're going to do when you find active disease if you're looking for surveillance, to pursue symptoms aggressively, to encourage patients to stay on the medicines you've already prescribed, and if there's persistent inflammation, consider a stratification scheme based on the risks of future problems rather than necessarily burning through all of your therapies without being able to achieve an outcome, which I would argue has not been proven to be obtainable.
Well, thank you, Dr. Rubin. You certainly make a compelling case. I can hardly wait for the faculty debate to start. Perhaps I'll go behind a shield here. But let's revisit the questions first that the audience was asked during the pre-webinar survey. So the first question of the two is, endoscopic mucosal healing in ulcerative colitis has been associated with all of the following except A, decreased colectomy rate, B, reduced hospitalization, C, reduced dysplasia and colorectal cancer, D, reduced relapse rate, or E, I'm not sure. So why don't you take a few seconds and make your choice, and then we will see how many of you were on the same page as our presenters during their debate.
This is a tricky question.
Yeah. You must have written it, David.
Does E count as a right answer?
It should be.
So 44% of you answered D, reduced relapse rate. 37% said reduced dysplasia and colorectal cancer. 11% said decreased colectomy rate. 5% said reduced hospitalization. And another few percent said that they really weren't sure. So it looks like that the reduced relapse rate and reduced dysplasia and colorectal cancer rate were the two most common choices amongst the questions. The panel, what was
the right answer here is that dysplasia and colorectal cancer have been associated with histologic markers and not endoscopic mucosal healing. So in the original study by Reuter that Tom shared with everyone, when they did a univariate analysis, endoscopic activity looked like a risk, but in the multivariate analysis it did not persist. And so it's actually histologic activity that seems to be associated with dysplasia and colorectal cancer.
Okay. Right. And there were the pre-question rate was about the same. So now let's move on to the last of our ARS questions.
We need to do that. There you go.
Okay. All of the following are reasons that mucosal healing and symptoms do not correlate in clinical trials of IBD except A, overlap irritable bowel syndrome, B, broad definition of mucosal healing, which classifies patients with active inflammation as healed, C, clinical trial indices are inaccurate, D, there's a time lag between assessment of clinical remission and mucosal healing, E, healed mucosa is not associated with improvements in clinical outcomes, or F, I'm not sure. So why don't you take a few seconds and make your choices, and then we'll see what the panel, what you choose, what the panel decides.
Oh, and I can see the numbers moving on your screen, Russ. It's very exciting.
It's very exciting, is right. Okay, the answers are pretty close. What's the panel's answer for this one?
Well, the right answer here was that healed mucosa is not associated with improvements in clinical outcomes. So the point of this was to point out all the different reasons why our clinical trials may demonstrate a difference in mucosal healing than the symptom outcomes. And that includes all the things that have been mentioned, having an irritable bowel, which gives you symptoms despite no inflammation or response to the treatment. The mucosal healing definition in clinical trials is often broader so that the endpoint is met in these clinical trials, and it may not be what we would all consider to be a true healed mucosa. We know the clinical trial indices are inaccurate. Tom did a wonderful job showing us that. And we also appreciate that there's probably a time lag between healing and symptoms and clinical remission. And I think the Extend trial with adalimumab may have suggested that, where some patients achieved clinical remission but not healing, and it may have been that they looked too soon. So there's a lot of different reasons.
And I think there's a very large, there are some very large points in here as well that didn't come out in our debate that I think are worth mentioning, in part based on what you've just said, David, as well as the discussion that's ongoing here. It was a bit of sophistry when I showed that there was really no correlation or a very limited correlation between disease activity index score and mucosal healing score. And that's when we use these as really quite broad measures. If we were, instead of having a quantitative scale on each part of a correlation coefficient equation, healed versus not healed, symptomatic versus asymptomatic, we might find that the agreement level is much better than that R value of 0.16 that I showed in that study. And these things really do measure a lot of the same things, even though we can argue, for the purposes of setting up a debate and bringing up these issues. But I think on a certain level, there's really a lot more agreement here between disease activity index and mucosal healing than we've led on so far.
Well, I certainly think that we've had a very stimulating debate on these issues, but there are a number of questions that have come in from our live audience regarding the presentation that I initially did, as well as the issues that you did, as well as some questions about inflammatory bowel disease overall. I want to start off by directing the first question from the audience to Dave Rubin, because this is kind of right up your alley. Is there a correlation between findings on a colonoscopy and the presence of dysplasia or colon cancer in patients with ulcerative colitis?
That's an important issue, and the traditional teaching was that you can't see dysplasia, or that it happens that you can't find it very easily. And so the recommendations have been based on that general principle that we should do randomized biopsies throughout the mucosa. We've come to appreciate that with the improved optics of our high-definition scopes, we can actually see a majority of dysplastic lesions that appear to be raised in some cases, flat in others, depressed in some cases, and we appreciate that. It also remains a challenge that when we're looking for such lesions, if the patient has active inflammation, we have some difficulty finding those lesions. Now, there's been a lot of discussion and interest in moving towards using chromoendoscopy or some kind of dye stain or even electronic filtering with narrowband imaging to better visualize dysplasia. But I want to point out that even if we agree that that's a superior way to find some dysplastic lesions, which it is, we have to also acknowledge that if the patient has active inflammation, chromo is very difficult, if not impossible, to use. So there's some details here. What I would say is that as of right now, the standard of care is to continue to do careful exams with your eyes open, target lesions that look unusual, and pay attention to those raised lesions. I still think that there's a role for some random biopsies to assess the presence of disease throughout the rest of the colon. And, of course, review dysplasia with a second pathologist and recommend second opinions and referral to surgeons when those things are found. Tom should probably add a comment.
Well, wait. Before I let Tom add a comment, there's a whole bunch of questions to the audience. We're running short on time, so let's direct another question to Tom. Tom, patients who have Crohn's disease surgery, let's say a curative ileocystectomy, do you rescope them at 6 months? And if so, what makes you decide to put them on a therapy?
So, an excellent question. There's really not great guidance for all of us on what we really need to be doing. I think that it depends on what therapy we've chosen, if any, for postoperative prophylaxis, and I think the evidence is quite compelling for the combination therapy of a metronidazole-like agent, albeit at a low dose for 3 months, plus ongoing thiopurines for selected patients, and then really to consider going and taking a look at 6 months and seeing how we're doing. It has become more and more my practice to look at 6 months than it previously used to be. I think we have wider choices in what we're doing. There are ongoing trials now to see if anti-TNFs are an appropriate preventive agent following an ileocectomy. We're just not there yet to make a blanket recommendation for all patients. I do look at 6 months. Sometimes I'll wait a year, but I do have patients on some sort of secondary prophylaxis.
And just out of fairness, I do too. We debated this issue, but this is a little bit of a different topic, and that's my practice as well.
Okay. There's a number of questions we've had about safety issues. Dave, what about a patient who is on an anti-TNF agent and develops a lupus-like reaction? Do you stop the drug? Can you use another anti-TNF? What's your protocol?
Right. So the so-called lupoid reaction or lupus-like reaction related to the drug has been estimated to occur as often as 1 in 1,000. Some people have suggested maybe more frequently than that, where a patient who's been receiving the drug starts to develop some kind of diffuse arthralgias, joint pains. They may even develop a rash. And coinciding with this, sometimes the drug is not working as well, but not always. In those situations where you suspect that may be going on, checking an ANA, a double-stranded DNA, and an antihistone antibody is an important way to assess this. And obviously withholding the drug if you're concerned they're having a drug reaction. These patients respond well to a short course of corticosteroids, and I usually wait until the double-stranded DNA titer has gone back to normal or near normal before I would consider another therapy. And I have gone to a second anti-TNF therapy in these situations. It's not been proven that this is truly a class effect, so I've been comfortable trying that.
Okay, so now I'm going to ask a few more questions from the audience, so maybe some quick answers. Tom, should we be vaccinating our patients against hepatitis B if they're not already immune?
Yes.
That's a quick answer. Dave, can we use anti-TNF agents in patients with hepatitis C? Do we know this answer? What do we think?
We do use it in patients with hep C. I would advise that you have a discussion with a hepatologist, or if you're comfortable managing it, you can treat the hep C. But the fulminant hepatitis with hep B has not been described in the hep C patients that have been studied.
And Tom, if you have patients who have active infections, do you usually hold the anti-TNF therapy? Do you continue treating through an active infection?
So, all active infections are not the same, and I really have, if it's a simple URI that's not too debilitating, no fever involved, I'll go ahead and treat small cellulitis, UTI, and the like. But anything bigger than that, I'm a little hesitant, and I hold it until the infection clears and then reinfuse.
Okay, and now maybe looking at a topic of monitoring, we have one more question. This, of course, is a quick answer from Dave, of course. Should we be testing TPMTs on all patients before starting azathioprine or 6-MP?
I do it in my practice. Is that the guideline for everybody? Not yet, but I would suggest it.
Okay. Well, that's the last question that we have time for this evening. I would like take this opportunity to ask Dr. Rubin and Dr. Ullman if you have any take-home points you want to leave the audience with. Dr. Rubin first.
Well, despite the fact that this was structured as a debate, I think you'll agree that Tom and I have a lot that we agree upon. And we're trying to push the envelope here so that we can achieve the same goals for our patients. We want them to be in remission quickly. We want to keep them there as long as possible. And, of course, we want to avoid outcomes like hospitalization, surgery, disability, or even steroid exposure. So it's really time for us to embrace the existing therapies that are available in 2011, use them earlier in our strategies, and get those goals for patients. Mucosal healing is an important endpoint, but treating to achieve that only is not quite there yet for us.
Dr. Ullman?
I would agree with so much of what David said, and I think that, Russ, you really laid out such a nice, concise series of arguments of why we want to think about being aggressive early. We still don't know who those ideal patients are, who the less than ideal patients are to do that. But we really need to keep in mind that sometimes we've got very limited periods of time to act and make a difference in the long term for our patients, and we don't want to waste that opportunity.
Right. Well, thank you again, Dr. Tom Ullman and Dave Rubin, for your compelling arguments, and thanks to all of our participants for joining us tonight. We hope that you found this webcast presentation informative. After the conclusion of tonight's webinar, please stay online, and you will be automatically redirected to an online evaluation form. After completing the evaluation form, information regarding how to obtain continued education credit for attending this webcast will be provided. We invite you to join us for the final webinar in the series, The Latest in Genetics, Risks, and Therapy Management in IBD, on Tuesday, April 26th at 6 o'clock p.m. Eastern Standard Time. The archive webcast will be available May of 2011. Thank you, and all have a great evening.
Good job, Russ. Well done. Time. You got warmed up.